on for the last talk of the session this afternoon. Thank you, Dr. Salah and Dr. Sakar, for the invitation of this lovely conference that I'm enjoying. So I was asked to talk about covered stents in iliac artery disease and how to choose between self-expanding and balloon-mounted designs. Dr. Schroeder gave us a great introduction into this topic, so I'll skip some of the slides where there was unintentional duplication. I have no financial disclosures. Just a reminder what's special about the anatomy of the iliac arteries. As you know, the aorta bifurcates at the level of the umbilicus. Then it gives relatively straight, short segment of common iliac artery, but dives into the pelvis, as you see on your right-hand side, and comes up at the inguinal level, inguinal ligament level, and gives the common femoral artery. And we'll see why this is important while we're choosing our stents. You heard about the task classification, so no need to talk about it. So just in general, when do we use covered stents? Is either we use it for atherosclerotic disease or as a barrier to exclude an aneurysm or to cover a dissection or perforation. And they come in two flavors, the self-expanding and the balloon-expandable ones. And just a very quick overview that all of you know that design-wise, the self-expandable one, they're made of flexible mesh, mainly from nitinol, which gives it flexibility, conformability, and gradual deployment advantages. And the disadvantages, it lacks the radial strength and limited use in highly calcified vessels. On the other hand, the balloon-mounted or the balloon-expandable stents, they're made of stainless steel or cobalt chromium, and they're mounted on a balloon that has to be inflated to release the stent. They have high radial force, precision deployment, better for osteal lesions, but they lack flexibility with the risk of fracture and risk of dissection. So just in general, how we choose based on the vessel anatomy, when we have a tortuous vessel like the external iliac artery or potential of kinking, again, the external iliac artery or the Hunter's canal in the femoral artery, we go with the self-expandable one. However, when we work with heavy calcified vessels or we need precision like orifices, we use balloon-mounted ones. So what does the literature tell us? Why covered, not bare metal? You heard from Dr. Schroeder about the COBEST trial. I'm not going to go through it. It showed better freedom from restenosis in task C and D lesions. However, the DISCOVER trial that was published recently contradicted that a little bit. It showed comparable results. However, when it came to technical success, complication, hemodynamic success, and it showed no difference in freedom from stenosis, occlusion, or target lesion revascularization. That being said, it's worth mentioning there were some patients crossover from the bare metal to the covered stent in that study. When the fresh thrombus was found, when the balloon burst, and with the residual stenosis, when there was migrating plaque proximally, or they needed to converge to CRAP due to dissection or perforation, or when the stents needed flaring, which wasn't an option. The real AI investigators, they looked at the outcomes after endovascular treatment for aortoiliac disease, and then subgroup analysis of 2,200 patients, they showed no difference between the self-expanding and the balloon-expanding stents. However, the Provismo registry, which was a non-randomized, multi-center, multinational industry-sponsored, they showed the 24-month primary patency for the self-expanding stents was better than the balloon-expanding stents and the combined stents. Also worth mentioning that the combined stents were used for complex vascular cases. So now we have mild preference towards the self-expanding. The ICE trial, they looked at both the self-expanding versus balloon-expanding bare metal stents, though, in this study, and they showed the risk stenosis much lower with the self-expanding stents compared to the balloon-expanding stents, and the freedom from TLR was higher in lesions with self-expanding stents. However, this was not translated clinically, as there was no difference between groups in the walking impairment, hemodynamic success, amputation rate, all-cause death, or pre-procedure complications. To summarize all these studies, the literature is not clear and a little bit confusing, but it shows that restenosis rates are lower with covered stents than with bare metal stents. Covered stents and both self-expanding and the balloon expandable ones, primary patency and secondary patency really high. It's about more than 90% in 5 years follow-ups. But the most important message today, I think, should be the choice between self-expandable and balloon expandable stents is the patient choice, and which should be depending on anatomy, lesion characteristics, and the need for precise deployment. And when the appropriate stent is selected for the right patient, usually they do well. I will illustrate that with two cases. My first patient came to me saying, I sleep in a chair. It's a 69-year-old patient with long history of claudication that for the last 5 months progressed to rest pain. He sits, that's why he sleeps sitting. He dangles his feet, developed edema and medial premalleolar ulcer, which worsened his pain. On the left side, he has external iliac stent and femoral popliteal bypass done years ago in another hospital, and he has the usual comorbidities. On exam, the right leg had dependent rapport with non-palpable femoral pulse with monophasic signals, and the physiologic studies, as you can see, very diminished. Given the absent femoral pulse, we obtained CT angiogram. And this is some representative images of the CT scan that showed porcelain aorta with patent left iliac stent and occluded right common iliac and external iliac stents and severely stenotic right common femoral artery. Dr. Hassan left, but old is gold, so we thought about it, and we thought, what shall we do? Shall we do right femoral endarterectomy and aortofemoral bypass? However, the aorta is unclampable. Shall we do crossover left to right fem bypass with femoral endarterectomy? However, you have to go through a redo groin and to clamp the previous stents because it's crossing the inguinal ligament. So went with the hybrid approach. We performed right femoral endarterectomy and percutaneous access on the left, performed a aortogram, and then I like to cross those lesions in anterograde fashion. The first one is up and over, and if I can, then I come from the brachial. We cross in an up and over fashion, have an through and through wire, and pre-dilated and stented the external iliac arteries with a Vibon self-expanding covered stent. Then we treated the common iliac artery with the balloon expandable covered stent, the ICA stent, also known as the V12 stent in Europe. And this is a summary of our treatment: bovine pericardial patch for the femoral, external iliac stent, and common iliac artery stent. Of note, I like always to stent distal to proximal in telescope fashion for the size mismatch. The patient, this is a before and after. The patient did very well, discharged post-operative day 1. His pain resolved and physiologic studies improved significantly and healed his wound within 3 months. Another example, I have a patient who couldn't keep a job due to his leg pain. He's a 60-year-old male patient, also with short distance claudication that we managed clinically for a year because he continued to smoke and we didn't offer him surgery. His symptoms worsened and progressed to rest pain for the last 3 months. On exam, he had pulseless left femoral artery, again, with monophasic signals, depressed physiologic studies. So we obtained CT scan. The CT scan showed small AAA measuring 3.3 centimeter with occluded left common iliac and external iliac artery. Again, severely stenotic near-occluded left common femoral artery. So again, we elected to perform hybrid revascularization. We did the left common femoral artery endarterectomy, percutaneous access from the other side. I tried to cross in anterograde fashion, couldn't, so went with the retrograde fashion through my endarterectomy and was able to get back in the aorta as you see here. Now, to stent from distal to proximal, what I do is usually I do a through-and-through wire for pushability and to be able to telescope it, snare the wire from the right side, and advance my external iliac stent. This is a pre-dilatation with a plain balloon, 6 millimeter, stented with self-expanding covered stent. You see 7, then built up to 8 on a low profile. And finally, stented the left common iliac artery. However, if you see at the bifurcation, now you see something new that wasn't there. And this is how we looked like with the team. It's like, what's happening there? And as my mentor used to say, we turned a good case into a great case. So now we have a dissection that's contained in the bifurcation of the artery. Decided to do a kissing stent to exclude it. So I reversed the through-and-through wire. I gave it up and reversed it back into the aorta, got an access from the right side, and placed the bilateral kissing stents over stiff wires here. Bilateral balloon expandable covered stents. And this is the summary. Telescoped Viabond self-expanding covered stents into a balloon expandable stent in the common iliac artery and with a kissing fashion in the aortic bifurcation. This is before and after. The patient did very well. Discharged post-operative day 2, pain resolved, and his stents were still patent at 18 months follow-up on duplex. Thank you very much for the invitation and for your patience. I apologize for going over time, and I hope to see all of you in Abu Dhabi one day.